All right, let's play detective today. We're diving into a case of acute kidney injury, but with a twist. The culprit? Well, it isn't coming from the outside, it's coming from within the body itself. This is the ultimate inside job.
You know, your kidneys are these incredible, tireless filters, but they're not invincible. And sometimes the biggest threats are the ones that are already inside the system. So, what really happens when the damage is an inside job? Let's follow the clues.
So here's our game plan. First, we'll cover the basics of what intrarenal even means. Then we'll look at how kidney cells can literally be starved of oxygen. After that, we'll investigate kidney poisons, both internal and external, and then move on to friendly fire from our own immune system. We've also got a crazy situation that happens when cancer treatment actually works too well. And finally, we'll put it all together to decode what the kidney is trying to tell us. Okay. First things first, let's define our crime scene. We're talking about intrarenal AKI. This means the problem isn't a plumbing issue before or after the kidney. The attack is happening directly to the kidney's own functional tissue. It's happening right on its own turf.
Yeah, so the key thing to get here is that this isn't about, say, a kidney stone blocking things up downstream or not enough blood getting to the kidney in the first place. This is direct damage to the machinery itself, the tiny tubes, the supporting tissues, the blood vessels, the whole shebang.
Now, let's look at our first major culprit, ischemic injury. And as you can see, we're calling this starving tubules. I want you to think of the kidney's tubules like these little high-performance engines. Well, ischemia is what happens when you cut off their fuel and oxygen supply. You're effectively starving them.
And check this out. The damage is super specific. It hits the S3 segment of the proximal tubule the hardest. Why there? Because that part of the kidney is the absolute workhorse. It's just burning through energy 24/7. So when the oxygen supply dips, it's the first one to go down.
So where do we actually see this happen? Well, here are a couple of classic scenarios. During huge surgeries, like a heart bypass, blood pressure can tank for a long time, starving the kidneys. Or think about someone with severe burns. The massive amount of fluid they get can cause so much internal swelling that it literally squeezes the kidney's veins shut, completely cutting off blood flow. Okay, so we've seen what happens when kidney cells get starved. But what if they're just straight up poisoned? Well, that brings us to our next category, nephrotoxic injury. We're talking about substances that are directly toxic to those really delicate kidney cells. And, these poisons really fall into two main camps. You've got your endogenous toxins. These are the ones our own body creates under stress. The ultimate inside job, right? And then you have exogenous toxins, which are things we introduce from the outside, like certain drugs or medical dyes. A perfect example of an endogenous or internal toxin is myoglobin. When you have a massive breakdown of muscle, a condition we call rhabdomyolysis, myoglobin just floods the bloodstream. Your body isn't built to handle that much of it, and when it gets to the kidneys, it acts like a poison to those tiny tubules. And here is the dead giveaway, the telltale sign for any clinician. The patient's urine turns this dark, reddish, tea-like color. Now, you might think it's blood, but nope, it's myoglobinuria. It's a direct signal from the kidneys screaming that they're being poisoned. Now let's flip to an external poison. That IV contrast dye they use for CT scans, it can be pretty rough on the kidneys, and it follows a predictable timeline. The injury starts to develop in the first day or two. Then the creatinine, that waste product healthy kidneys get rid of, it peaks around day 3 to 5. The good news? It usually sorts itself out within about a week. This brings us to a super important safety alert. For patients on metformin, a really common diabetes drug, who already have iffy kidney function, you have to be so careful. See, if the contrast dings the kidneys, they can't clear the metformin properly, and that can lead to a life-threatening buildup of something called lactic acid. So the rule is simple and it's firm. You stop the metformin 48 hours before the scan. All right, next on our list are two very different problems. One is basically an over-the-top immune response, and the other is a physical blockade. Just think of it as friendly fire from your own body and some major issues with the supply lines. So, you know how some people get a skin rash when they have an allergic reaction to a drug? Well, that same kind of reaction can happen deep inside the kidney. We call it acute interstitial nephritis, or AIN. So, how on earth would you even know it's happening? What are the signs? And bam, here it is, the classic triad. You have a patient who just started a new medication, and suddenly they develop a fever, they get a skin rash, and their kidney numbers start to go south. You see those three things together? You have got to be thinking AIN. Now, this is where the detective work gets really cool. Look at these two completely different conditions. AIN is an allergic reaction. Atherosclerotic disease, on the other hand, is when little cholesterol crystals literally break off and clog the kidney's arteries. Totally different problems, right? And yet, they can both produce the exact same clue in the urine, eosinophils. It's a perfect example of why the whole clinical picture is so important. Okay, our last scenario is a real medical paradox. It's called tumor lysis syndrome, and it's an emergency that's caused not by cancer growing, but by killing it off too quickly. That's right, a successful treatment can actually create a brand new, life-threatening problem for the kidneys. So what does this metabolic chaos actually look like? Well, as tons of cancer cells burst open, they spill all their contents into the blood. The easiest way to remember the mess is with the mnemonic puke. You get high phosphate, high uric acid, and high potassium, which is K. The E stands for accept calcium, which actually goes down because it gets all bound up by the extra phosphate. This is a huge problem. So the name of the game here is being prepared. For patients who are at intermediate risk, we're going to start a drug called allopurinol before chemo even begins, and we're going to push a lot of IV fluids. But for the high-risk folks, you got to bring out the big guns, a more powerful drug called rasburicase. The strategy is all about anticipating that flood and protecting the kidneys at all costs. So we've really covered a lot of ground. We've seen how kidney damage can be a true inside job, caused by everything from starvation and poisons to friendly fire and even successful cancer therapy. The key to it all is learning how to read the clues, how to decode the signals that kidneys are sending us. So let's just quickly recap the big takeaways. First, when the kidneys are starved of oxygen, it's the hardest working cells that get hit first. Second, toxins can be an inside job, like myoglobin, or an outside job, like contrast dye. Third, a single clue, like those eosinophils in the urine, can point to very different stories. And finally, sometimes the solution to one problem, like killing cancer, can create a whole new emergency. And that really leaves us with one final thought. Being able to spot these different patterns, it's not just some academic exercise. Each one, from that tea-colored urine to the fever and rash, points to a totally different cause, which demands a different, immediate action. So the real question is, how does spotting these inside jobs change your entire game plan from the very first step? Thanks for joining me.